Welcome to this most recent episode of the Akkad and Coco Report. Today we have the pleasure of having Dr. Martha Gulati here. Dr. Gulati is the Division Chief of Cardiology for the UA College of Medicine, Phoenix, and Physician Executive Director for the Banner University Medicine Heart Institute. She's also the best-selling author of Saving Women's Hearts and Editor-in-Chief of ACC's CardioSmart. So incredibly well accomplished, and we're super honored to have her on the show today. We have her, so welcome, thanks for coming.
Thanks for having me.
We have her on the show today to discuss a recent paper by Dr. Norman Wang. Dr. Norman Wang wrote a white paper which was intended, in his words, to provide an overview of policies that are intended to impact the racial and ethnic composition of the cardiology workforce. And it was somewhat of a treatise on affirmative action, the history of affirmative action in the United States, and as well as how it applies to medicine. There was quite a firestorm of controversy just in the last week after it came out, and the paper has since been retracted. So Dr. Gulati is the chief of cardiology. She's also an editor. So we're very interested to hear and discuss, her views on this as well. So, Dr. Gulati, have you had a chance to? You must have had a chance to read the paper at this point.
Yes, I did read the paper. It has been retracted, so you can't pull it up right now, I think, from what I could tell most recently.
I wonder if there's a market for retracted papers. I downloaded a copy. If anyone's interested, we'll take contributions. And
the black market of retracted papers that are no longer available. So when you read the paper, what parts of the paper did you find troubling?
Well, almost all of it. It tried to frame itself as a paper that was going to use science to answer the questions, but it was very selective in what it picked out. I think that was one of the troubling things, is that it even quoted people, but took quotes that were not with the rest of the statements, so didn't even make sense by themselves, and certainly wasn't what the authors of those papers even said. So that was part of it. Interpretation of data as well was not, again, very selective. The way that it was presented was not what the data actually really showed. And in the end, I think, when you think about all the things that the AAMC is trying to do in terms of getting underrepresented minorities into medicine, and from a cardiology standpoint, of course, since it came from a cardiologist and it was, in a cardiology journal, we've been making such big efforts trying to get a more diverse workforce. And it basically, the conclusion of it was that affirmative action doesn't work, and that also we've badly selected fellows in training or in the past or even present. And I had many colleagues and fellows who felt that basically it was attacking them, that everything that was in that article was representing exactly themselves, that they were part of that. So are you saying that you aren't as well trained, you aren't as good as other people? And I think that part was incredibly hurtful. And I know hurtful doesn't matter if the arguments were valid. Our feelings can be hurt, but if the argument was valid, then let's listen to it. But a journal like JAHA is not going to just pull an article for being hurtful. They're not going to retract it just because it hurt people's feelings, but it was actually that it's flawed. And so my understanding is that they are planning on publishing a rebuttal to help people better understand what was actually wrong in the article.
That's so. It was a surprising paper to read. I didn't hear about it until I'm sure you were the same way, because the article was published in March, right, in the midst of the pandemic, and that's
why we all missed it, because someone did say, where this has been out for months, and then we were all reacting to it in the last few weeks. And I really think it is because we all missed it in the pandemic. What were we doing? We had the pandemic was happening. We were all shutting down. Everything else was going on, trying to reorganize our work. For our fellows, they were trying to, reimagine their life and training. So there was that going on. And then shortly after that, the American College of Cardiology scientific sessions happened. And so that, I think we were all paying attention to that because we were home. Additionally, I don't know if it was the same for all of you, but I was reading anything I could get my hands on about COVID because I felt very ill-equipped and didn't know what we'd be facing. We were listening to webinars from China and webinars from Italy and sharing information, which was fantastic because I think our international colleagues helped prepare us. But I wasn't reading in the same way my general cardiology journals. And I think we all missed it because when I went back, I found a tweet from somebody, at least in early April, outraged by the article. And unfortunately, it was not someone that I necessarily followed. I follow her now, but I never saw it. And it was like a voice that really wasn't heard, unfortunately.
Yeah. So, in order to try to talk a little bit about what people find objectionable in the paper, one of the interesting things, you just don't really discuss the matter in much depth or detail, among regular colleagues. Like a lot of people have certain opinions here and there, but we don't really get into some of the historical framework of it. So I actually was really unaware of much of the some of the history that was described. One of the interesting things he does is separate out the history of affirmative action into phases by years, and he talks about how the first phase, phase one was 1969 to 1974. And again, this is probably one of the things that seems objectionable. This is what he talked about in 1969 is when kind of things started in medicine. The two primary objectives put forth by the AAMC, that's the American Association of Medical Colleges. That was when the Office of Minority Affairs came about, and this all actually was catalyzed by the assassination of Reverend Martin Luther King. And the subsequent riots that followed. And one of the kind of new, so there's some, you can see that there's some parallels to what's going on now to what went on then, unfortunately, both tragedy kind of catalyzing an attempt to try to do good and do better. And, one of the things that was said that they laid out in 1969 was the AMC laid out in 1969 was to advocate for population parity in medicine, meaning proportional representation of what the population was. And so at the time, Blacks were estimated to be 12% of the population. And in medicine, the medical school class of professionals was only about 2%. And I guess this is the part. And so that's just describing what is. It's hard to object to that. But again, the last sentence in that little passage there says, it later became apparent that the AAMC short-term goal was missed. They had these short-term goals of how many more Black and underrepresented minority applicants they wanted. And he says that it later became apparent that the AAMC short-term goal was missed because of a paucity of qualified candidates, particularly Blacks. Is that the kind of sentences that you found objectionable?
Well, yes, on so many levels.
Yeah.
It makes me cringe inside to say that to hear that being said. I think that it isn't that we haven't found qualified candidates. We haven't worked hard enough to get qualified candidates. If you look at it, in 1978, we had 542 Black men matriculating for medical school. And the last data I could find was from 2014. This was in a 2017 paper. 515 Black men graduated from medical schools across the United States. So we haven't made a dent in all those years. We aren't looking for them. And if we only have 2% of our faculty in academic medical centers being Black, how are we ever going to attract people? How are we going to help kids that might struggle? There's always somebody who you connect to when you're a medical student. And if it is reassuring to see people like yourself in any setting. It really doesn't always mean that they're your mentor, but they have that potential. We don't even give them a fighting chance. And I think we have a long way to go. If the only good thing that came out of this article is to reinvigorate the discussion of how do we get there, that's great. But I don't think we can, that it's acceptable to make that statement at all. And it horrifies me. I don't know if I have to qualify this, but the author of that paper is my former fellow when I was at Northwestern. And it is very hurtful. I read his other paper. I don't remember now when it was published, but it was in JACC. And he was disturbed by the ACC categorization of Asians of any sort into Caucasian, like basically not giving them, I believe, a separate categorization when they're looking at underrepresented minorities and their representation within the cardiology community. I think certainly if there's a lack of representation of Asians or South Asians in cardiology, then certainly we should be looking at that. But that actually isn't the problem. There is other issues, and we can, people can talk about them, but I don't think in medicine, I think we're overrepresented actually compared to our population presence. So I'm not trying to say that that's, that everyone has worked very hard to get into medicine, but we're not giving people from different backgrounds a fighting chance to get their foot in the door. The more we look like our patients, the better off our community will be overall.
Right. No, certainly, Dr. Gulati, but just on the statement that Anish was referring to, I was just, he has a reference at the end, and I just looked it up. It happens to be a reference. So the statement again is that the short-term goals of the AMC were not met because, quote, according to his words, because of a paucity of qualified candidates, particularly Blacks. And then he puts a reference to a paper from 1977 from the New England Journal, and I just pulled it up, and it says, again, it's from the abstract here, if Black underrepresentation is to be corrected, the pool of qualified Black applicants must be increased. So that's in the New England Journal making that statement
right
back in 1977. So it doesn't seem to me that it's, at least at that level. I mean, there are certainly other parts of the paper we can talk about, but right.
So the question is that Michelle's bringing up is that a you brought up early on that this distinction between we don't retract things because they're hurtful, we retract things because they're false. And so we live in a world that we have, not in a world that we necessarily, we all want to build a more beautiful world. And interestingly, that reference cites is a 1977 New England Journal of Medicine paper. And there's been a Dr. Gulati, a version of Dr. Gulati in 1977 that has been trying to do the exact same thing, right? And as you nicely point out, we have not succeeded. But one of the really interesting things was that paper is in the NEJM that cited its Black underrepresentation in the United States medical schools. It's by Boyd Sleeth and Robert Michel at the time. And the point they raised in the paper was that, and they were talking about, this is written from a context of how do we increase, like what are the issues that we're having? Because since from 1969 to when this kind of special article is being written in 1977, you've had 8 years now of affirmative action. And so these folks are writing now to say, okay, what's happening? How's it going? And what do we need to do better? And what they said in the paper was that, look, we are struggling for the last 8 years to try to increase Black underrepresentation. And that comment comes from this thing, and I'll just quote, this is not me editorializing, this is me just quoting exactly what the 1977 paper says. the problem of few Black applicants is compounded by the fact that many of the applicants are poorly prepared for medical school. As compared to white students, Black medical students are less likely to be promoted with their class and more likely to drop out or be dismissed. In 1970, 77.8% of first-year Black medical students and 97% of white students were promoted with their class. So that means only 77% of first-year Black medical students versus 97% of white medical students were being promoted. So thus, academic dismissal, and they go on to say, and the need to repeat first-year studies are the major causes for lower promotions of Blacks than of whites. The other interesting thing they say is that, interestingly enough, of the Blacks who entered medical schools in 1969, that was the first year that medical schools began to adopt affirmative action policies, far fewer graduated with their class than Blacks who entered medical schools in 1968. So there appeared to be a concerted effort in organized medicine in 1969 to try to increase representation of underrepresented minorities. In this case, they're specifically talking about Blacks in medical school. Yet they're struggling to do so. And the conclusions of that paper, this is 1977, and hopefully we've learned more since, and you'll tell us more, no doubt. But they said that, look, it is going to be impossible because of the vast discrepancy that exists at multiple levels of education up to medical school. It is very hard at the medical school level to do this and to succeed at doing it. And really what you need to do is focus way earlier in the food chain in terms of education, so that we have more of an applicant pool to pull from that will be able to make it through medical school. So I mean, I wonder, in that context, right? I mean, if Dr. Wang reads that paper, I'm sure I hope he read most of the citations. If he reads that paper, is that statement then, again, he's saying it later became apparent that the AMC short-term goal was missed because of a paucity of qualified candidates, particularly Blacks. I mean,
well,
does it fall into the category of hurtful, but true certainly for the paper for that time period?
Well, maybe for that time period, but again, that's 1977.
Right.
Of course, things haven't changed as much as we want them to change, and there's still obvious issues in our, differences in education in the United States, depending on your zip code, depending on where you grew up, and often dependent on race. And that is true, but I think quoting and saying that failed, that's using, yes, it's a qualified reference, but it's so old that doesn't represent, I think, here and now. Right. And I think, again, you need to be, I don't disagree with what you're saying. Yes, we need to start earlier. We all know that. We're all working towards how do we get underrepresented people at an earlier stage. I think we have a program at University of Arizona that we did with inner city girls to try to get them in high school, to get them interested in cardiology. And, there's a lot of different STEM programs that are around the nation trying to do that. And certainly that's part of some of the solutions. But I don't think that we're at the same place as we were in 1977. And I think that there's a lot of other things going on in our society that are affecting it. But why have we not changed? Why aren't we being active as a medical system, as a medical school system, as AAMC? Why are we not being active at trying to retain more Black faculty? How can we only think that it's okay to have 2% of Black faculty given our population?
Yeah. Well, I don't know that, do you think it's the case that it comes from a lack of effort or ignorance on our part? Here we have in 1977, folks decrying the fact. This was not a article against affirmative action. This was an article saying, we did affirmative action, we're trying to do affirmative action, we're struggling to make it work. It seems like there's been a concerted effort within organized medicine to try to do this for a very long time. And I guess the one question raised, is it a fair point that at the medical school admissions level, is it too late to try to now make this, create, more faculty, et cetera? Meaning, is it the case that we need to be working much harder, much earlier on, I guess? as a solution. I'm not as a solution to try to get more folks, more faculty in academic medicine, or more to have more Black cardiologists, etc.
Well,
Is it fair to say that, or would it be a reasonable point to say we need to start much earlier than?
It's reasonable to say that we should start earlier, but I don't think it's true that our current that we're making the effort. I think that's not entirely true. Some schools are making the effort, and where they're making the effort, they're being successful. So when I was at Ohio State University, and I worked very closely with Quinn Capers, and Dr. Quinn Capers is a cardiologist as well, very well known, and he, before you could even be on the medical school admission committee, you had to do training on your unconscious bias. And everybody, if you want to be part of that, you had to. We ended up implementing it in all forms of hiring, actually, but for medical school admissions, that was clear. As a result, we were a school with a significant portion of underrepresented minorities in our medical class, and they did well. So, you can look at our numbers. You can look at numbers of schools that actively have that progressive attitude, and then you can look at schools that don't care, that they'll say, well, we're going to do it this way. Yes, do we have to sometimes weigh different things, and that could be for any culture, to be honest, and any race. If things happen in their lives that might have affected their scores differently, yes, but that wasn't specific to any one race. But you have to be more proactive about it. And I really think that not every medical school is. Some medical schools absolutely are held against doing that. They actually are against affirmative action. It's in their bylaws. They can't necessarily look at that and aren't looking at that. I think that's wrong. And so I think that's where we're having the breakdown. I do think that, I'm not saying that, but I just don't think 1977 is the same as 2020 either.
No question. I get the point that I guess the discussion is on how does one achieve the goal of diversifying to a greater degree. Meaning, what are the steps that you need to go through to get there? Of course, there have been a number of Supreme Court decisions because this has been such a controversial topic for so long, right? And one of the Supreme Court decisions, I think it's referred to over and over again. The Supreme Court decision says affirmative action, meaning using race as a part of an admissions process, is okay. But they have certain caveats. And one of the caveats says that the policy must demonstrate that it is not a quota. It must demonstrate that preference is not awarded solely for race or ethnicity, and that having a policy of race and ethnically neutral efforts have been insufficient. Also, they go on to say it does not cause undue harm to non-favored racial and ethnic groups. So that's kind of the established way that affirmative action is thought to be legal in the United States today. Is that a reasonable thing? I mean, Supreme Court decisions can be whatever they are, and we can disagree with them. So, but do you think that's is that a reasonable base to start from, a reasonable agreement to start from, that affirmative action, meaning race-based stuff, can exist, but it shouldn't be a quota, and preference shouldn't be awarded solely for race or ethnicity? And the other part is it doesn't cause undue harm to non-favored, whatever the racial group that's being favored by affirmative action is.
Yeah, I don't have a problem with what the Supreme Court rules, but I think in medicine there is some differences. Look, we have racial differences in outcomes in cardiovascular disease. We have evidence, strong evidence, that if you improve the diversity in the class, in a medical school class, that it improves, empathy, it improves racial understanding, it improves connection with patients and comfort with patients of different backgrounds. I think when we look like our patients, especially, there's evidence that patient satisfaction is better, which is a measurement that we're all being measured on. And doctors spend 2 minutes longer with people who look like them. And not that all those things necessarily matter in the end, but they do matter to hospitals. They do matter for how we end up caring for patients. I think, though, the actionable items we should make in the medical schools and in our hospitals is making diversity actionable, value and a priority. And I don't think that every hospital does that. I think the unconscious bias training should be part of everyone's education. It shouldn't be optional. I think we all need to know where our biases are, at least so that we can respond to them or check them at the door sometimes when they're actually occurring. I think cultural competency training matters. It doesn't matter where you come from, but you're going to take care of people with different backgrounds, different upbringings, different socioeconomic status. These are things that can help us be better doctors. Examples, teaching about the differences in care, how we treat underrepresented minorities and why their outcomes are worse would help them appreciate, because everyone thinks they take care of people equally. They do. If you ask them, they all think they're taking care of people equally. These can be built into our medical education. I think my work is all about sex differences, and I think it is a similar bias. Everyone thinks that they take care of women as well as they do men, and providing that education is also a way to reduce those disparities. But I think having people that are from the community where the disparities exist can help us have a sensitivity and understanding of that culture and make us better, no matter where they come from. And the next thing we'll talk about, probably 10, 20, hopefully not that long. Let's hope it's only a few years down the line. Right now, so we're talking about race, but we have to think about other underrepresented populations like gay and lesbian and transgender and bisexual people, which right now get the worst health care as well. And the same issues, they're underrepresented in our medical community. And how do we improve that? How do we make them feel more welcome? How do we get a more diverse community? I think the idea of diversity is just so that we can all learn and share from each other and be more aware of the issues that exist in our communities. And I felt like this paper undid, or maybe revealed, a lot of things that almost took us back 1,000 steps, where we're like trying to make these steps and then someone saying, well, it didn't work anyway, and so we shouldn't be doing this anyway. And that's just not true. We have evidence for that. And I think the rebuttal, I think, will provide us with a lot. I know people that are working on that right now. It's not me. But I think that we need to be more open-minded about creating this diverse environment and making sure underrepresented minorities in our community are being pulled into our medical school and pulled into our faculty and hired as well. I think there is something to be said for people seeing people like them. They're more likely to stay. You said about people more likely, from that older New England Journal paper, that people are more likely to drop out, and we have some evidence for that for sure, or more likely to not matriculate with the class that they started with. If you have no one you can turn to in your medical school that looks like you, or if you're struggling, and even if people are treating you differently, which can affect a medical student greatly, if you don't have people to turn to, it makes it very hard. The more you have diversity, the more likely kids will be successful in medical school, regardless of where they came from.
Sorry, go ahead, Michelle.
Yeah, so Dr. Gulati, I think those points are very well taken. But so Dr. Wong in his paper quotes at the end, and what seems to be a different viewpoint yet of somebody who was in favor of, again, affirmative action. He quotes Faith Fitzgerald, who's a faculty at UC Davies, and she also published in, I think, 1981 or 1984, I can't remember, an editorial in the aftermath of the Bakke decision, Supreme Court decision that Anish was just mentioning. And her viewpoint, I mean, the quote, I'm going to quote it here. She says, "We will have succeeded when we no longer think we require Black doctors for Black patients, Chicano doctors for Chicano patients, or gay doctors for gay patients, but rather good doctors for all patients." And that seems to be a bit of an alternative, right, approach to what you were just saying, where in fact you say we need to have, because of implicit bias or because of biases that cannot be overcome, we need to have more representation of minorities to take care of their own, and so forth. Do you, at least, I mean, one may disagree legitimately, but do you think that there's that at least Dr. Fitzgerald's viewpoint, would you characterize it as necessarily being racist in and of itself, or that it's
I don't have any, I think none of us have that problem. That's our viewpoint, is that once you create a more diverse community, we will all be better equipped to take care of anyone. But I think by having diversity in our medical school, we learn appreciation for people from different backgrounds. We learn a lot more. I mean, we all learn from our medical school classmates about their culture. We become more sensitive. We become more appreciative of the differences and the things that they go through, and we become more educated. It's just like the example, so just let me go back to sex differences. In the emergency room, there was a study about, the care of women patients, and women took better care of women coming in with a myocardial infarction than men did, except the men that were in hospitals with lots of women in their department. And then there was no difference. The women took just as good of care as they did of women as they did in men. That didn't seem to matter, but the difference was in the care of women. So there's something about having women in the environment, and maybe they're pointing out these differences of how women present, and that helps the men appreciate those differences and be more actionable to them when they're taking care of female patients. The same can be said that, that we, in an environment where there is a lot of diversity, we're all going to learn from each other, and it's going to create an environment where we are better equipped to care for anyone. And that's ultimately, I use that example for sex differences all the time, that, it doesn't require women to take care of women. I don't believe that at all. But I think that, one day we'll get to a point where we can close the disparities in care for women. And the same, there's disparities in care for how we care for underrepresented minorities. The same thing could be abstracted. And I think that's, of course, I actually totally agree with that statement about you won't be looking at the type of doctor, because we won't look at people and look at them differently, because we will understand the differences in our society.
Yeah, I read that paper as well, and it's an interesting paper, because it's like I'm always struck by them, because when we come into hospital, when a patient comes in the hospital, there's this massive team of folks that are taking care of them, right? And so many times, like the most vital link in that chain, sometimes it's the triage nurse who recognizes that this EKG looks really abnormal and triggers its own, right? And that saves you 15 minutes of muscle, and they get to the cath lab earlier. I had a unit clerk, I remember once, who, when I was on the floor, I happened to be on the floor seeing somebody, and we had a really good relationship, and she was like, "Oh, Anish, you have to come, this person, he just looks really bad. You need to come see him." And, there was some nurses were on break or whatnot. And it was a unit clerk who called out and brought out, and the guy was having, some significant ST elevation MI, and, luckily got to the cath lab pretty soon. I'm pretty sure if, everyone kept going and he hadn't discovered 30 minutes later, that things would have gone much, much worse. And so, that particular paper uses the first the attending in the ER, what gender the attending in the ER is, as the shock, if you will, to try to decide then, okay, who does better, who does worse.
Which isn't perfect. I agree that that's not, I'm not going to hang my hat on that study.
Yeah. But that's the, that's the thing that always troubles me with a lot of these papers, whether it be papers that relate to race concordance or paper that relates to sex concordance. It's like these studies are like, there's never a compelling story as to how that happened. The conclusions of that paper specifically, they even note it. They say, we cannot directly observe the reason for this disparity. And we had this interesting economist on a couple of weeks ago, and we're talking about econometrics, because there are all these econometrics and quantitative papers that are coming out, like natural experiments, right? So this is part of where you get Dr. Jena has done a lot of stuff. Anupam Jena, I'm sure you've seen his name on all sorts of papers where he finds that if cardiologists go to conference, that's the natural experiment that shows, oh my goodness, mortality is higher when cardiologists are mortality is lower, when cardiologists go to conference. And whenever guys, I'm not a researcher, I'm just a lowly clinician at the bedside. I was like, how does that happen? It's like, if you can't give me a good story to understand how that, and this is what the econometrician, who is not in medicine at all, he was saying this, he interestingly said the same thing. He said, look, if you can't tell a compelling story as to how exactly this association you're seeing is happening, I don't, as you're saying, you say yourself, you wouldn't necessarily hang your hat on it. If a pharmaceutical company tried to sell some new drug based on this level of evidence, we'd be like, I'm not sure about this. And that was the other bone of contention in the paper that he picked out. So Dr. Wang, I think, has picked up on this a little bit, and basically says, by no accepted measures of causal inference, can you say that diversity is in and of itself a good that we must chase because it improves outcomes? Because a lot of the papers are very similar to what you're describing. There was an RCT, it's a preprint and NBR study, which looked at Black physicians and white physicians and matched by gender. And it was actually a randomized control trial, which is rare in this area. But even that study, massive extrapolations. It was based on preventative care measures that Black physicians were offering Black patients, and they found that Black patients, had a higher uptake of those type of interventions at that one whatever that visit was, right? And they based that to say, okay, if this were to hold across the entire population, and the study was like 9 physicians or something like that, then you would save this many million lives, and we would make this much of an inroad in the big outcome differences that exist within races. And as I mean, the historical legacy of slavery, racism, low socioeconomic status, historical redlining. I mean, the laundry list of stuff that anyone that's been awake knows about. Those are such complex things, and it always seems to me to be a little simplistic to necessarily be able to throw these things at it. But diversity is a fantastic goal. How big of a difference we can definitely get, is it debatable, I guess, Dr. Gulati? Like, based on what I've said in terms of the level of evidence stuff, is it debatable to say that diversity is going to give you a massively different outcome in underrepresented groups?
I'm not sure if I'm clear what you're asking.
If
we do more diversity, we'll have a more diverse.
Will we have better outcomes? Will we have better outcomes? Do we know for sure? I mean, because this is like I'm saying this is like hydroxychloroquine level of data. You'll have in terms of, that's the level. I'm not.
No. Do we need more evidence? Yes, but do we continue to stall our progress waiting for that? I don't think so. My experience with underrepresented minorities, and again, I know this is I'm not giving you science, but my experience is many of them work much harder to get where they are. They're judged differently, how they speak, whether you come from a different country, whether you have a different dialect from a different, you're judged based on that. If you sound like the typical white male, you're okay, and everybody else is at a bit of a disadvantage. And I think often people are having to prove themselves, and I think certainly our Black medical students work very hard. There's a double standard, and I have this, there's this great resident from University of Chicago, and she draws cartoons. And if you've ever seen them I see them on Instagram, but I shared it after this whole controversy on Twitter. And, it's sort of that baggage that she carries is like, am I here because you just accepted me, but then also, don't talk differently, don't look different, don't, don't sound angry when you bring up differences. There's a lot of things going on that I think that we're not addressing if we're not addressing making our community more diverse. I agree with you. Do we need more data? Absolutely. I think that would be important for us because it will make a difference to the justification. We have in the United States, as you well know, that there's a greater mortality in the African American population from cardiovascular disease. Even though we've known about it, we continue to under-treat them, under-aggressively treat them. All of our Get With the Guideline data and national inpatient sample data all concurs with this. We should try it. Let's have the experiment then, if that's what people need. Let's get more people into our community and see what happens to those numbers.
Yeah, I actually wasn't arguing for more evidence to say that we need more diversity in the physician workforce. I don't know that I'm saying that I don't know that if we have a proportional representation among the medical school, among medical school graduates, doctors, than the population. I don't know that alone is going to be enough to fix some of these massive ills that have been, 200, even more years in the making. I think it's a good thing to push for diversity, even if we are never able to prove beyond HCE level data.
That's right, because I think it seems like a double-edged sword. If you ask for more data, and suppose the data doesn't show what you were hoping for, then it seems that you would give ammunition to a Dr. Wong to come up and say, listen, we've looked at the data and it doesn't, it doesn't achieve the goals, and therefore, so I think it's reasonable to say that diversity is a good in its own right, and not pay attention to the data and say, or pay attention to the data, but not hang the decision on empirical studies. But at the same time, it seems to me, and I'd like your comment, and I know there will be a rebuttal from Ja, but I'm not a specialist, but I think he failed. I mean, he tried to present his paper with at least a historical overview that he was trying to be objective and factual about the different phases of how the legal system has evolved and the Supreme Court decisions and so forth, and then a second section where he looked at precisely the kind of evidence as to what these affirmative action programs have done based on the data. So I mean, it didn't seem to me sort of outlandishly. I mean, clearly he has his opinions, and they're clear at the end in his conclusions. But it seems to me that it's the kind of academic work that one might see, and I'm wondering if his conclusions were different, yet the methods were the same. I mean, do you think? I mean, clearly he doesn't believe in these affirmative actions initiatives. I mean, and it's clear, but should he be penalized and he was demoted, or by virtue of picking the wrong kinds of studies, or by virtue of having the wrong conclusions about them? Is a question that I think is fair to ask, because it seems to me that on the surface the methods, the level of studies that it
wouldn't be the first cherry-picked article.
Right, exactly. I mean, there are many articles that publish many papers with the same kind of evidence that are to defend a certain viewpoint.
But to cherry pick everything in your favor of what your argument you're making is a bit problematic. But I think that even if I still think it would be flawed. It was a flawed argument, and that to me is the most important point. But should he have been demoted based on it? I apologize for my dog. Should he have been demoted? Yes, I do think that if he is a fellowship program director and the institution's goals are not aligned with what he repeatedly is representing, then I do think he should be demoted. They will never attract a diverse audience into their EP fellowship with someone like that if he's making the decisions. So I do think that is one thing that I don't feel that he was unduly penalized. He still has his job, which I'm actually surprised about in some sense, because being in an institution where their goals are different, he may not align. And they put out a pretty strong statement, UPMC did. So I think it's hurtful to his program what he wrote, and hurtful to residents and fellows from underrepresented backgrounds. I don't really think it was the wrong action. I think first of all, the other issues I had with the paper is it was actually listed, you might have noted, it was listed as a research paper. That's how in the section it was in research. It's not that it was new research. He just used other data and presented an argument. And he himself called the paper a white paper, which, we can go there if you want to, but that's what he labeled it as. But I don't know that anybody gave him, usually white papers are assigned to a group of experts. And I've never seen any such paper by one person and one person alone. I think that the journal itself, I think, they came out with an apology. They came with the retraction. I think that was all important. I think that they do need to think about, especially with papers like this, though, having somebody with a background in diversity to look at these papers to make sure that they're based on, if they're going to publish them, that they're based on the science, not cherry picking and not misquoting and using information to make your argument versus not looking at the other side or the other data. And I think that is one thing. I mean, obviously it's up to the journal to decide that. But what I think many of us were surprised about, that it went to obviously probably more than one reviewer. It made it through the editorial process where they decide if this is something the journal wants to publish. I don't get how it got through all those phases and ultimately got published. And it just, again, makes me wonder about for any of us who've had rejections of articles, or wondering well, how did mine not get just why didn't it get published if this could so easily get
right?
FFR is very controversial, right? And Dr. David Brown is famous for being very anti-FFR in terms of using it for PCI. And whenever I read a David Brown article about FFR, however it's published as research, meta-analysis, etc. You know the conclusion he's going to pick, and how he selected the data to say. He quotes FAME 2, and when he quotes FAME 2, he talks about the definition of MI is that's why. So the NEJM paper that says, hey, look, there was a difference when you use PCR. It's in a randomized controlled trial. There's a difference when you use FFR. But he will of course, and all of us have done it. I mean, all of us do this where we take apart a paper, and even if the paper says, the New England Journal RCT concludes with X, right? He picks out and says, well, it was badly done because of X, Y, and Z, and my conclusion of this paper is this. So I wonder if that's what whoever peer reviewed this particular thing, saw this as yes, he was trying to use the data that existed to support his argument. And I guess that's the question. I guess the question is, you're chief of cardiology. I guess, is it, so you probably should not be involved in any type of you would not have anyone on your faculty that disagrees with affirmative action.
Well, I mean, you can't can't know everybody's agenda, right? Like you can't ask them to check off,
Right.
do you believe,
Right.
do you not believe? What you do is you try to be the role model for what you want and speak out for your, the types of fellows you want to attract or the programs that you want to
Right.
create or have discussions. We in fact, we brought in as one of our special speakers during last year, we had Dr. Quinn Capers come and it was a cardiology grand rounds to internal medicine.
Right.
And we had everyone listen to him make the argument for diversity in medicine. And I think you role model that kind of behavior. You bring in those people so that people can learn more. The more you hear about it, the more you'll understand what the issues are and where we need to go. But of course, you can't ask your faculty, what are your issues?
Will you be inviting Dr. Wang to also give a talk to your fellows on?
I don't think so.
But actually, to press this point a little bit, Dr. Wang cites. I mean, clearly, let's granted it may be a minority view among blacks or underrepresented, but he quotes an economist, Thomas Sowell. He quotes Arthur Ashe, and I know of several other either black economists or prominent black people who have been critical of affirmative action in general, or who hold the view, for example, that affirmative action and programs like this, for reason X, Y, and Z, in the long term, do not benefit the black community. And if you wanted to benefit the black community, you should do A, B, and C instead of X, Y, and Z. And and again, one can maybe be very critical, and maybe those positions are no good and whatnot. But holding those positions, does that rise to the level of necessarily being labeled a racist or not having a place in academic journal, precisely, for example, or being invited to give a talk or a grand rounds to actually promote those views, granted that they are cherry picked, but nevertheless, it's not physics, right? It's the kind of things where people may legitimately have disagreements.
Again, if it's based on science, it's worth the debate. When it's cherry picked and misquoted the way it was here, I don't believe that it deserves a platform. I think that it's always worth us discussing, what works, what doesn't work, how to make our community better and stronger. I just think that when there's an agenda, I would want to say one thing though. You said, I wouldn't label the individual as racist per se. I think that there's lack of understanding and appreciation, but I do think I think our system might be racist in the sense that, there's inequities in some racial groups, and there's over equities, if you will, in other racial groups, and our perspective and how we learn and all the other things are based in the United States more on a white person, and in fact probably a white man attitude, and we have things that we need to change. I think we should be debating things as we are scientists, and we want to make sure we're using the best science, and we want to provide the best care to patients. But I don't want to label people in a certain way, but I don't think we should be giving them a platform unless they're using science to make their argument. And I didn't feel like this paper was.
I just wanted to touch on the one part of things that Dr. Wang brought up, and also that is brought up in this debate not infrequently. Harvard was recently sued Harvard was sued because there was this idea that you were discriminating against Asian Americans. And I brought that up in the earlier thing that, affirmative action is kind of allowed to take place by the Supreme Court, provided there's no quota, and also provided that you don't unfairly discriminate against, a group that's non-preferred. So one of the things he raised was Dr. Capers actually talking about the fact that in 2014, just 2.7% of American cardiologists were Black. Hispanic doctors made up 5% of the physician pool that year, and while the remaining majority fell into another category, white. And that raised his hackles, and I'm sure if it raises his hackles, it probably raises some other people's hackles in terms of in the Asian American community say, well, why are you considering us as white? We are a significant portion of Asian Americans, are a significant portion of that pool, and why should we be categorized as white? It almost seems like a way to make medicine appear not very diverse. Is there anything to that in terms of, there's a lot of Asian Americans have had their own struggles, and they're not Black American struggles, certainly. Do you feel like that in any way diminishes the struggles of Asian Americans in terms of getting to where they've gotten in medicine?
No, absolutely not. But I think that by us making a more welcome community, we make it more welcoming for everyone. Certainly anyone of any non-white background, to be honest with you. Anyone who looks different or speaks different will be treated differently, whether it's when they're applying for medical school or applying for even university, when they're applying for their advanced training. There's judgments being made solely how somebody appears. And there's stereotypes that we have for certain races. But I think, again, I'm not saying that Asians or South Asians don't deserve to also be in their own category. I actually do agree with that. I don't think we're categorized as white, although my worry then is they'll see that we're a big proportion of medicine too. I think that we need to make room though for everyone. We actually, there's room for everyone that wants to really study medicine, in the sense that we're soon going to have a population with not enough physicians the way we're going. We're not investing in new trainees, and we're having an aging population. Who's going to take care of all of us as we get older? I think that we need to just start being supportive of every race. And I think that that's where we judge specifically Black Americans very differently. And I think that if we look at this, that we're all in this together to make our society better, it's going to help everyone, because we judge everybody differently. Everybody has their biases, whether it's male, female, whether it's the color of people's skin. And we really need to start thinking about that and making a difference to correct that.
Right. This idea that we are not making a, before I get to that, do you not feel like if we want to be more proportional, if that needs to be the goal, then Asian Americans are vastly overrepresented in the populace? And do there need to be fewer Asian American physicians in order to qualify? Because it seems like we don't want then a lot of Asian Americans that are taking care of, African American, Hispanic, etc. Is that do we become a problem then within the group?
Right now we're the problem. I think we're leaving a significant portion of people out of the healthcare field. But I don't think that there's, I feel there's room for everyone. And I don't think that we're taking a spot from somebody. It's how do we want medicine to look? And that's a decision way bigger than me. And how do we want cardiology to look? People need to make those decisions within their own universities and act on them the way that they feel appropriate. But I think the places that are making active decisions to try to be more inclusive and make people more culturally competent will create the best cardiologists.
Right. This idea that we are not doing enough to try to pick up and retain folks that are healthcare professionals that are Black and Hispanic, is that at all countered by the fact that when you look at objective test scores, that we have a greater leniency in that specific objective mark, right? I'm not saying that's bad, because as you've said before, everyone has their stories. Objective test scores don't represent the wholeness of a person, doesn't necessarily represent how good you are going to be as a physician, correct? But at least it's an indicator that medical schools or the admissions committees are trying very hard. So the fact that, if you have an MCAT of 25 and a GPA of 3.3, that the acceptance rate for Black physicians is 65%, and for Asians is, under 10%. How does that jive with the idea that we aren't trying very hard to keep and get Black and Hispanic applicants, do you think?
Well, I mean, first of all, I think test scores are, we're moving away from them. So who knows what that's going to translate to our medical system, that test scores are now going to be, a lot of them are moving to, they pass them or pass and fail. So who knows what we're going to have in our future. And I think, GPAs, again, I think, in the US, that's so much affected by, like we started out with, where you get educated to begin with.
Right.
The differences in the public school education based, again, on your zip code. I'm not saying that we're not making the effort, but we're obviously not making enough. We're not getting enough of our underrepresented minorities into medicine. And I think that there's strategies that we have to look at, whether maybe it's, like you said, maybe it starts earlier. And I think a lot of people are thinking we have to start earlier. We have to give them role models earlier in high school, give them opportunities to shadow doctors, to kind of know what they do and get them interested in medicine. We need to improve our school system. And we could solve all the world's problems, I guess, tonight too. But there's a lot of things that we need to do if we really want to answer this. But again, I don't think that, I think your data is more valid than the data that I read in this article, where it picked out the data it wanted to present. And I think that if we focus on the article alone, that is not, it's basically, the conclusion was we've selected people who are subpar, which is just not true. I think people from different backgrounds are judged harder, actually. And I think that is something that we also need, not harder maybe based on scores, but when they're in our training programs, how they perform is a very different judgment. And we have such subjective judgments of how we score applicants, or not applicants, how we score our fellows and our residents in terms of the check boxes that we take through. And there is big differences, both based on race and based on gender.
Does the decision for hiring, firing, does that usually rest with the chief of cardiology? Is that basically your role, or is that your committee's role, or how does that?
I think nobody takes firing lightly. I mean, it can, obviously, if someone, but I think, so it has to either violate, where they've either put somebody in harm's way, or they violated some sort of code of conduct. Right. And I think that would really be up to both the university, and I think that's what, I don't know that what their code of conduct is and what where he is at. Obviously, it isn't enough to get him fired, but it was enough to say that it might affect his choice of picking certain fellows, and it would be the wrong message based on what UPMC sees as its goals in terms of its training and education of the next generation. So there was people that were very upset, saying that they didn't think he should be removed from being a fellowship program director. I actually think that he should have. I mean, that seems to be inconsistent with what the values of that university is.
Right. Is there an unofficial code of conduct that say encompasses Like suppose a faculty member in your division, there was some Facebook post of them wearing a MAGA hat. Does that constitute, not values that are consistent with? I mean, how it becomes, or suppose like what constitutes acceptable behavior? It seems like.
Let me add to this. I mean, are you sensitive to the criticism that universities and academic centers in general tend to lean, one particular ideology, or you sort of have one political view, and then it's not very diversified in that, from that standpoint. And what would you make of that? I mean, sort of more broadly than what we've talked about.
Well, I think it's, everyone signs a contract with their university and their hospital. If they violate something that is within their contract, it can be fireable. For behavior outside, it probably doesn't matter unless it puts the hospital itself in poor lighting. From a university standpoint, I don't think that they would necessarily fire someone. When you publish something under their name, I don't think that they would also be able to fire you based on your writings, but they can use that as whether they would renew a contract or something with you. That's a decision for them. I think every institution, every hospital is different. Now, a lot of our physicians are signing agreements with not the university, but with the hospital. So all of those decisions they're big decisions. And like I said, I think the only thing that I saw that was the reprimand was that he's not the fellowship program. And I don't think that is an incorrect action.
All right, Dr. Gulati, we've taken up way too much of your precious time. Thank you so much for coming on. Really enjoyed the discussion.
All right, thanks a lot, guys.
All right.
Thank you.
Bye.
Thanks so much.
Bye-bye.